Next we have Dr. Maria Tinu PG, Assistant Professor, Department of Ophthalmology, Government Medical College, Ernakulam, to explain about VEP to us.
Good morning. My topic of presentation is a role of VEP in disc edema. So what is VEP? So VEP is a visual evoked potential. So these are the electrical potential initiated by the visual stimuli that are recorded from the scalp overlying the visual cortex. So they are used primarily to measure the functional integrity of the visual pathway or quantifying the functional integrity of the visual pathway. So in the previous section, Madam said about what is the importance of doing MRI. So I am doing a simple comparison between the VEP and MRI. So VEP explains the functionality of the visual pathway, whereas MRI gives information about the structural and anatomical information of the disease. So it is lateralizing VEP, but not localizing, whereas MRI gives information about where the disease is the localizing property. So under the given circumstances, they may be complementary to each other. So we can divide the VEP on different types based on the stimulating frequency, based on the types of stimuli. So based on the stimulating frequency, we can get a steady state VEP because here the stimulating frequency is high, so in which the next VEP starts before the previous response ends. So we will get just a sinusoidal waveforms. So it is not used routinely because the parameters we use is the amplitude and latency. So they get inferior information about the amplitude and latency. Whereas in transient VEP, if the stimulating frequency is less than 3 Hz, we get a discrete deflection. So we will get information about the amplitude and latency. So this is a commonly used one. Based on the types of stimulation, it can be flash VEP or pattern VEP. So a pattern VEP is again divided into onset, offset, pattern reversible, etc. In flash VEP, the importance is it should be used in those patients who cannot fixate, having poor cooperation, and having media opacities. The problem is it is a cruder response. There is intersubject and intrasubject variation is there. We get 3 negative and 3 positive waves. So you should use flash VEP in a patients having poor vision. Whereas in pattern VEP, the first type is the onset-offset type. Here the checkerboard pattern is made to appear and disappear. The importance is it should be used in nystagmus patients because if we are using pattern reversal VEP in nystagmus patient, it will exacerbate the nystagmus. So you should use it in nystagmus patients. And the waveforms we get is the C1, C2, C3. It is opposite that of flash and the reversal because the first wave is a positive wave followed by negative wave, then again comes the positive wave. So the first C1 at 75 milliseconds, C2 at 125 and C3 at 150 milliseconds. Coming to the most reliable waveform, that is a pattern reversal VEP. We get mainly three waveforms. That is the first is a definitive N1 negative waves which occurs near the 75 milliseconds from the visual cortex. Then comes a prominent positive P1 peak at 100 milliseconds from the dorsal extrastriate cortex of mid-occipital gyrus, and the N2, that is a negative wave, which is variable. It can range from 135 to 145 milliseconds. It's from several areas, including the parietal lobe. And the important parameters is the amplitude and latency. What is amplitude? It is a time between the start of stimulus and the main positive peak. It is measured in milliseconds. Whereas the amplitude is the peak of N95 to peak of P100 in microvolts. So there are many factors, including the physiological factors, affects the VEP waveforms. They include size of stimulus, sharpness, brightness, speed of pattern reversible, and the physiological factors like age. Because age, we can see the prolongation of VEP latency. Then sex, females have more amplitude. The eye being tested, right eye have more amplitude. And depth anesthesia, you should use, if in children, you should give light anesthesia. Then pupil size, we should test in undilated pupil. The visual acuity is also important to select which type of visual stimulus or which type of VEP you should use. And the problem is each study shows different values for VEP, latency and the amplitude. So each lab is expected to demonstrate its own normative values which can be used as a parameter. So the P100, again it is the most consistent, most reproducible and the least variable waveform in VEP. So coming to the clinical protocol, the interpretation of VEP should be considered within the context of patient symptoms. patient's clinical examination, and all the tests mentioned in the previous section, like OCT, RNF flow CT, GCA, MRA. So it should be considered within the context of all other symptoms, information available about the patient. So first you should correct the refractory error. You should done an dilate pupil, use a pattern reversal VEP stimuli of 1 degree check size if the visual acuity is more than 6/60 and there is no nystagmus. So it's the best choice in cooperative patients with a better visual acuity. You should take at least 2 average VPs to verify the reproducibility, and the pattern reversal is twice per second, and we follow the 10-20 international system for placing the electrodes. So here I am doing a simple comparison between the VEP waveform in optic neuritis, anterior skim optic neuropathy, and papilledema. In optic neuritis, there is P100 latency increases significantly. But VEP amplitude can be decreased as the disease progresses, but the significant change is the increase in latency. And the later the disease resolution occurs, the latency were found to decrease significantly during the first year and less significantly during the second year, and the most marked changes occurring between the 3rd and the 6th months, possibly due to the remyelination and channel reorganization. So here in the picture, we can see the right eye, the P100 latency is around 105 millisecond, whereas in left eye, which is affected, have 145 milliseconds. So there is a difference of both eye with 40 milliseconds. Coming to the anterior skim optic neuropathy, the definite change is a decrease in P100 amplitude. But there can occur a normal to mild prolongation of the latency also. So in the latency prolongation in anterior skim optic neuropathy is much less than those in optic neuritis. So in the first picture, the P100, we can see in the picture, we can see there is definite decrease in the amplitude, and there is only a slight prolongation of latency in the left eye. Papilledema. So in papilledema, the VP waveforms can be normal, or it can be P100 latency can be prolonged. So the problem is in elevated ICP may affect the VEP waveforms through its effects on the intracerebral structures rather than on the optic nerve. So we can notice increased VEP latency in the patients having hydrocephalus without papilledema having increased P100 latency. Maybe its effects on optic radiations, and after surgery, shunt surgery, or even after lumbar puncture, we can see there is improvement in P100 latency. So in this first picture, in right eye and left eye, the P100 latency is around 127, 126, whereas in the second picture that is done after lumbar puncture, it is around 109. So come to conclusion, you should interpretation of the VEP should be done within the context of patient symptoms, patient's clinical examination, and other investigation modalities. Thank you.
Thank you, Dr. Tinu. I think our time has